All right, welcome. Thank you everybody for joining. Welcome everyone to day 2 of the California Pan-Ethnic Health Network's mental health briefing. We are a statewide multicultural health advocacy organization focused on eliminating persistent health inequities and addressing structural racism in healthcare, including mental health care. We are so excited to have you all join us at this virtual event. We'd like to go over just a few housekeeping items. If we could go to the next slide, please. All right, so just a few housekeeping items here. Everyone is, oh, you know what? I don't know if this is the right slide deck, Aviva. I think we need to go to day 2 slide deck, which is on Fox, and it's titled 1119. Sorry about that. Let's just figure this out for just a moment. Thank you all for your patience. All right, while folks are joining, I will be going over the housekeeping items verbally. So please change your Zoom name to your full name so that others know who you are. Everyone is muted. And feel free to use the chat box. Introduce yourself. Let us know your name, your organization, and your pronouns. If you attended yesterday's briefing, which was day 1, share with us one thing that you enjoyed about yesterday's briefing in the chat box. If you are new today, share with us why you joined the mental health briefing today. So we'll just give folks a minute to start introducing themselves. All right. Great. Okay, so I'm going to move forward and let you all know what our goals are for today. So moving on to the goals of today, we have 3 goals. The first goal is for us to discuss the role of the pandemic in nationwide protests, what it has taught us about the impact of racism on mental health. Our phenomenal opening speaker, Mr. Chet Hewitt, will provide opening remarks on the issue. The second goal is for us to bring together policymakers, legislators, and thought leaders to discuss opportunities for us to make our mental health delivery system work better for communities of color. That session will be facilitated by Lauren Gustus, who is the editor of the Sacramento Bee. Lastly, we are going to showcase 3 local programs that are actually working to reduce mental health disparities. We're going to hear from a new set of programs today that are actually working to reduce disparities among Native American and American Indian communities, trans and non-binary youth, and what one organization is doing to help grassroots CBOs contract with county behavioral health departments. Really exciting. Our dynamic community advocacy director, Mihei Jung, will be moderating that discussion of 3 local programs. So what we want to emphasize to you about today is that racial equity must be at the core of addressing mental health disparities. I said it yesterday, but it bears repeating. Solutions are not out of reach. And in order for us to do this work, we need to have a grasp of what the policy opportunities are, what's already working and showing positive mental health outcomes in communities of color. And so that's what we're going to do today. So now let me introduce our opening speaker. We will be joined by Chet Hewitt, who is the president and CEO of the Sierra Healthcare Foundation. Chet Hewitt is the president and CEO. He is also, over the past decade, has been a bold collective impact strategy leader focused on promoting health and social justice in underserved communities. Prior to joining the foundation, Chet spent 5 years as the agency director for the Alameda County Social Services. We are so lucky to have you join us today. Please welcome Mr. Chet Hewitt.
Thank you. Good afternoon, everyone. It's really an honor to be here. I want to thank CPEN and Karen and her wonderful team for putting this together and for all the support and getting me centered in my remarks that I'm going to make to you today. You know, as I started thinking about my remarks, I was having this experience of having this tragically sad song replay over and over in my head. And if you ever had that experience when you hear a song and you just simply can't get it out of your head, and sometimes that song isn't your favorite song, or sometimes it's not even a very happy song, but there's a refrain, or what we call the proverbial hook, that just keeps replaying itself over and over again. And if you've ever had that experience, you know, one of your great wishes is, let me get something else in my mind. Let me figure out how I can get this song out of my head and set it aside in some way. I know you're saying, this is about race and disparities. And, what's this guy talking about songs for? What does that mean? Well, you'll see in a minute, because I'm going to ask you in your own way to repeat a refrain that showed up over and over again. As I was looking at some of the latest research and data about mental health and what's happening in association with the pandemic in preparation for these remarks. And that refrain is heightened concern for racial and ethnic minorities. I'm going to share a couple of data points with you. And then I'm going to say the refrain. And you should say to yourself, a heightened concern for racial and ethnic minorities. So, according to the APA, there's been a huge increase in the number of individuals who are actually seeking mental health support. Apparently, they say that the number now is as high as 11.8 million on a monthly basis. And of those 11.8 million American adults who are seeking some kind of mental health or behavioral health support, the vast majority said that they could not access them. The report goes on to say that of the unmet need, 38% said it was because they couldn't afford it. 28% said they thought they could handle the problem without treatment. And 21% said they did not know where to go to get the treatment they needed. It went on to say that access and affordability. Now, we've heard these terms before when we think about the experiences of healthcare for folks of color. Access, affordability, and quality remain concerns. Now, this was a report that looked at everyone across race, ethnicity, and class. But towards the end of the statement around the ability to access mental health services, there was a refrain, a common refrain, one we hear over and over again. I'd ask you to repeat it to yourself out loud or in your head. There was a concern or a heightened concern for racial and ethnic minorities. According to a recent CDC report, there has been a sharp increase in the percentage of survey respondents who have experienced a level of anxiety, stress-related disorders so severe that they have actually contemplated suicide. And that number amongst the general population was about 40% of those particular respondents. In that report, it also said that more than 20% of essential workers have also reported suicidal ideation and were much more likely to act upon that. Now, essential workers, as we all know, are more likely to be people of color. 53% of all ag workers are actually Latinx. And most people don't realize is that over 30% of all nurses in this country are actually African American. Now, given the impact on the essential workers and given the race dynamics associated with that, there was a heightened concern for racial and ethnic minorities. Another point to data. In that same survey, 75% of young people reported having a recent adverse mental health challenge. And we know that in California, young people up to the age of 18, about 73% of young people in California are actually young folks, children and youth of color, with Latinx youth making up some 52% of our youth population. And we know that access to services for them that are culturally specific and sensitive and accessible and affordable do not meet the level of demand or need that we see out there as well. Now you think about this, 75% of the almost 6 million children in California who do not identify as white could possibly having a mental health crisis in which they will be challenged because of the issues around wealth disparities, health disparities, access to care, and the quality of services they're likely to get, which means many of those young people will not have the type, quality of services they need to find their way to health. Another data point with a common refrain. It was reported in the New York Times, in the Wall Street Journal, that the economy is now a significant source of stress, anxiety for Americans. And that was almost 70% of Americans actually say they had some stress because of the economic state. And it's 55% of those who are experiencing some level of financial difficulty. If you look at the latest data, you know that the unemployment rates across race and class look very, very different for people of color than it looks for folks who are white. In fact, if you see in today's Sacramento Bee, it was reported that 83% of Black workers in California have filed for unemployment. 83%. And we know that the economic stress associated with the stresses that we have around community transmission, who's likely to get ill, who's likely to get sick, and the quality of care you're likely to get. It's just additional stresses on the backs of folks and communities and families of color. And if you read through that report, there is a common refrain. And the refrain, once again, is there is a heightened concern for ethnic and minority communities. I start my remarks by saying that, when looking through some more recent data, I felt like I was listening to a really bad song. One of those tragic songs that has a refrain that plays over and over again in your head, and you really wish you could get it out. It is an uncomfortable and unsettling feeling to think about living through a pandemic, which has incredible physical and behavioral health implications. To know that they are exacerbating long-standing challenges, both systemic and structural. The biases that you have if you're fortunate enough to get services, and the structural impediments that often don't fund or place services of sufficient quality in locations and places and spaces where folks of color can actually access them. And then you layer on top of that level of economic dislocation that people are having. You can play that record over and over again in your head. The refrain is tragic, it's repetitive, and you hear it again and again. And you begin to realize that it really is time to change the song. They say when you have that experience that one of the most effective interventions is to actually play a different record. Is to get up, and you know you're having this experience where it's playing in your head, and click on your iPhone or your Spotify or whatever it is that you get your music from these days. Me, every once in a while, I'll go throw on some John Coltrane on my phonograph. Yeah, it's old school, but it works. And it allows me to actually think or change what I'm actually experiencing. Now, I hope my metaphor is hanging together well enough for you to understand what I'm saying. Because the work that many of you are doing is changing that particular song, is changing that particular record, is standing up the kind of infrastructure and policy and practices that would make some of the data points that I offered here today different. Wouldn't it be nice in the years to come to not have to experience the disproportionate dislocation, tragedy, and misery that those metrics actually capture, and have it disproportionately be borne on the backs of communities of color? Wouldn't it be wonderful as we think about mental health, as we think about our pushback against racism and anti-Blackness, and for our brown communities and for our Asian communities, that we could actually have a mental health system that takes into account these particular concerns across the board and is really positioned to do something about it. This notion of changing the song and this metaphor is about what we'll have a conversation on today and in the days, weeks, and months ahead. Because unlike the virus itself, which hopefully over the next 6 to 12 months will be addressed by issues around that are made available, or interventions like a vaccine and like some of the public health measures that will limit the transmission of the illness. But the behavioral and psychological implications of what we're experiencing are reported or expected to last for decades. The experience that people have actually had, dislocation of kids from schools, the dislocation of families and individuals from work, and then the attending behavioral and mental health conditions that kind of trio behind it. So I'm hopeful that as you participate in today's conversation, that you'll hear from some folks who are really thinking deeply about this. I hope that you will be inspired by what you hear and by what others are actually doing. Because I don't want this to be a simple recitation of a level of tragedy and harm that community is experiencing, because that is not my point at all. The intervention, the ability to say you can change the song, hopefully is a hopeful message, because that is something that we can do. Kind of social and structural constructs that limit our ability to get access to the type and quality of care we need can in fact be changed. It'll take hard work. It'll require us to work across lines and divides that sometimes we don't reach across often enough. But it is in fact possible. My hope for today is that new bridges are built, new ideas are shared, and that it isn't simply a one-way conversation, that it'll be bi-directional, that you'll hear from some experts and that you will share your expertise and your knowledge with others who are participating in this forum as well. The ultimate goal is simple: a brighter future for us all, a healthier future for us all. One that isn't just predicated on sayings du jour, build back better, or others, but to build back differently, with equity at the center, with justice at the center, and with health at the center of all of our conversations, economic, social, as well as around health, as broadly stated as possible. That is the hope for the future. And I hope that today is a continuation of the agenda that will actually get us closer to being in that particular state and place where we can actually say progress is being made. I want to close out by just wishing you a great conference. And I'm hopeful that path that we all need to be on is not as unavailable to us that it may sometimes seem. And that some of the more recent changes that you've seen on the political and social landscapes will give us great hope. That we're not simply yelling in the woods, because that is not our goal or interest, but that we are really blazing a path to a brighter and healthier future. I'll stop there, and I'm looking forward to hearing and sharing with the folks who will be coming on the panels after my remarks. Thank you all.
Thank you, Mr. Hewitt, for those really powerful opening remarks. Thank you so much for also introducing all of the data and the importance of setting an agenda that we can actually see through. I am now going to introduce a pre-recorded session that will actually be moderated by the Sacramento Bee, which is one of the largest, most prominent newspapers here in California. As Mr. Hewitt referred to, is showcasing quite a bit of data on the impact of COVID-19 on the mental health and health of communities of color. So I will be introducing a pre-recorded session that will be moderated by Lauren Gustus, who's the editor of the Sacramento Bee. It's not often that we can bring together thought leaders, legislators, advocates, and prominent newspapers together to engage in a conversation about exactly what Mr. Hewitt is saying. What is the agenda, the concrete steps that California can take to actually implement and improve racial equity in mental health? So during this pre-recorded session, please feel free to stand up, stretch, get yourself some water. CPEN staff, we are also going to be dropping pre-prepared questions into the chat box for you to respond to and interact with each other. We want to hear from you how this discussion is resonating. Please use the chat box to interact with CPEN staff and with one another. Aviva, please take it away with the pre-recording.
Hi, I'm Lauren Gustus, president of the Sacramento Bee and West Region editor for McClatchy. Thanks for joining us for this conversation about California's mental health response to the coronavirus. We are 9 months into the pandemic, and calls to local domestic violence organizations across California are surging. 4 in 10 Black, Latino, or mixed race people are reporting symptoms of anxiety or depression at above average rates, per a recent report from the California Healthcare Foundation. Who is impacted by the coronavirus pandemic is tied to inequities in access to care and the resulting behavioral health crisis. It's possible that anxiety, depression, substance use, and deaths by suicide might not yet have peaked. Just this week, we learned that 20% of observed COVID-19 patients are diagnosed with anxiety, depression, or insomnia within 90 days of that coronavirus diagnosis. And yet, over the summer, 31% of California adults said that they had taken steps to improve their mental health since the start of the pandemic. We are persevering, we are doing what we must, and yet we can do much better. So today we'll talk about what our challenges are and how we can continue to support each other in the months ahead. We'll spend some time on what's working in California as we look to move into 2021. This conversation is being hosted in partnership with the Pan-Ethnic California Health Network. Special thanks to them and the work that's gone into planning the session. I'd like to introduce our guests and then we'll dive right in with questions. But first, and because this program is being shared across California and McClatchy's 5 news organizations within the state, we want to let you know that there is support available. If you or someone you know needs help, please call the California Peer Run Warm Line at 855-845-7415. You can also text Talk With Us to 66746 to connect with a trained crisis counselor. We'll put that information up on the screen as well so you have it available. So we're going to welcome 3 guests today. Let me introduce them, and as I said, then we'll get going. Dr. Sandra Hernandez is president and CEO of the California Healthcare Foundation. Prior to joining CHCF, she led the San Francisco Foundation for 16 years. She has also served as Director of Public Health for the City and County of San Francisco. In 2019, she was appointed by Governor Gavin Newsom to the Healthy California for All Commission, which is charged with developing a plan to help California achieve a healthcare delivery system that provides coverage and access through a unified financing system. She's a graduate of Yale University and Tufts School of Medicine. Welcome, Dr. Hernandez. Thank you for joining us today.
Thank you, Lauren. Nice to be with you. Good morning.
Good morning. We're also joined by Dr. Joaquin Arambula, who was elected in 2016 to represent the 31st Assembly District in the Central Valley. He's the first Latino physician elected to the California State Assembly, and he represents a district that includes 41% of the city of Fresno, as well as rural cities and counties in Fresno. Rural cities and communities in Fresno County. Welcome, Dr. Arambula.
Thanks, Lauren. Great to be here.
Thank you. And finally, we're joined by Kieran Savage-Sangwan, who's Executive Director of the California Pan-Ethnic Health Network, a statewide multicultural health policy organization. She is the architect of many recent CPAN bills in Sacramento, including the measure that requires hospitals to have a discharge plan in place before releasing poor and homeless people, which became law in 2018. Kieran also worked as Director of Legislation and Advocacy for the National Alliance on Mental Illness, California, and as an organizer focused on immigrant rights for the ACLU of Northern California. Welcome, Kieran.
Thanks, Lauren. Happy to be here.
I'm interested in Dr. Arambula's position or perspective, on what is happening in the Central Valley. What are you seeing in your communities as you look at the impacts of the coronavirus on your constituents' mental health?
Thanks, Lauren, for allowing me to be on this panel. Anytime I get to be with Dr. Hernandez and Kieran, I know it's a good day. And we are trying to figure out some of the solutions that will work for California. So if you will allow me, I'd love to tell you about where I come from. So I was born and raised here in the San Joaquin Valley, which is the breadbasket of the world. And many of the same fears and anxieties and depressions that all of us throughout this state are feeling, we are also feeling here in the Central Valley during this pandemic. What I would say differentiates us from much of the state are what we determine or call the social determinants of health. Much of the abject poverty or living conditions or the lack of access to healthcare really affect the way we get to engage with our healthcare systems. If you also add, for many of our immigrant communities, the cultural and linguistic complications or lack of competencies, as well as the immigration fears, help to compound many of the mental health challenges that are occurring here in this pandemic. But what I'm seeing firsthand here on the ground is really a need for support and services. And so I look forward to the conversation with many of the thought leaders here and would love to follow up as well with Dr. Hernandez, as I believe that telehealth, specifically looking at behavioral health, is one of the major opportunities we have to rise out of this crisis stronger than we went into it.
Thank you. And we will return to that. Kieran, I want to get your read on, as you take a look at what's happening across the state, what has worked in terms of the pivots that California may have made or that we're seeing in specific communities where there's a greater or more significant response than others. Do you have any specific examples of a community-focused solution that you might elevate for this group and writ large, so that we could begin to dive into, okay, and where do we go from here?
Yeah, it's a great question. Thank you, Lauren. So I think when we look at the COVID response broadly, one of the things that California has done that we think is really important and we haven't seen in any other state is really saying, as we think about how to reopen our economy and we think about how to control and contain the spread of the virus, we are going to focus on the communities that we know have been hardest hit. And so the state has very clearly set out sort of a standard for counties to meet to say, you can't have a giant gap between how your most affluent communities are doing with COVID and how your poorest communities are doing with COVID, essentially. You really have to focus and invest resources where they're most needed. And so that is a statewide policy that we think is really important as we go forward and ensure that we can safely reopen our state without leaving anyone behind. I think specific to mental health as well, one of the things that we see in terms of the disparate impacts of the pandemic and that we really worry about is grief and loss, right, as a mental health issue. Because we know that nearly 1 in 3 Black and Latino Californians know someone who has died from COVID-19. And so those communities are really experiencing a depth of grief and loss that I think is profound and that needs to be addressed. And so one of the programs in California that we really embrace is the California Reducing Disparities Project that really looks at, in different counties across the state, how do we develop community solutions, right? So for example, in Los Angeles County, how do we develop sort of peer support opportunities specific to Black women who have been impacted by the pandemic in numerous ways, right? How do we ensure that we have culturally competent outreach, education, support in the Korean community in Orange County? These are all things that are made possible because in California, we made the decision a number of years ago to increase our revenue for mental health services through the Mental Health Services Act. And it's allowed us to do innovative and different things that are also responsive to a time like this. And then finally, I will echo the telehealth piece, which I would love to get into as well, because I think one of the things we've seen in COVID is really exacerbating the access to healthcare gaps that our communities have experienced. And we do think that telehealth is promising in terms of addressing that challenge.
Let's make that transition. Dr. Hernandez, you mentioned it first. Where do we need to go? What have we learned? And what can we apply as we move forward with respect to telehealth and or other solutions as we move into 2021? And as we know that we will move into 2021 with the pandemic for at least the foreseeable future.
Sure. Well, Lauren, I would say that, one of the things that has slowed historically the use of telehealth and telemedicine, telepsychiatry in particular, has been the lack of revenue capabilities to be able to pay for those kinds of services. And what happened at the outset of the pandemic was really an acknowledgement that telehealth and telemedicine was going to be a very significant tool for access. And those restrictions faded away through CMS, through these kind of special rules that were put in place. And, I personally think as we think about access to mental health more broadly, stigma is something that that we continue to struggle with in terms of understanding mental health and how we look at it societally. And so telehealth and telepsychiatry really allows people to access psychiatric services wherever they are, and in ways that are much more discreet in some ways than maybe having to go to a particular clinic or the like.
Thank you. So much there that we could unpack. I have a follow, and I'd like to direct it toward Kieran. I'm interested in what your organization is seeing with respect to who is using telehealth and how we might further break down the barriers, either from a perception standpoint or from an access standpoint. And I'm talking about, do we have a reliable internet connection? Can we make an effective and meaningful, relationship work in the digital space? So interested in your perspective on who is using it and what the barriers are to greater adoption.
Yeah, great question. And we just conducted a statewide survey of people of color who have utilized telehealth over the last 9 to 12 months, asking about the experience, partially because we didn't know. I mean, like Sandra said, we have really rapidly evolved to broadly use telehealth this year in 2020. And we really weren't sure, is it working, particularly for people of color, or are there still challenges? And so we conducted this survey, and what we found is overwhelming satisfaction with the telehealth experience. And this was across primary care, mental health, substance use, and specialty care. And it was across different populations in California, as well as in different languages, that people really want to have the opportunity in the future to choose telehealth when it's right for them and for the type of care that they're seeking. But we did find certain challenges. One that you mentioned, Lauren, really the access to the technology. And we found that it isn't just video, but a lot of people are using their phones, right, to access their medical care. And people are running into issues of limited phone plans and not having enough minutes on their cell phone to be in contact with their provider, right? So I think that's something really to pay attention to as we think about the delivery system, how we ensure that there's appropriate reimbursement also for phone-based care, but also that consumers have access to that. We also heard, particular to mental health, that there can be challenges with people having a safe and private place in their home to conduct their appointment. If people live with many different people in their house, if they're trying to seek care somewhat confidentially for a mental health or substance use condition, that really having that physical space is important, and it's not something that we can assume that people have. And then finally, we continued to hear challenges really around language access, which sort of surprised me because I was thinking, okay, technology, this should make it so much easier to coordinate interpreter services. But people are still really running into issues having an interpreter or a provider who speaks their language, which I think also speaks to the workforce issues that Sandra alluded to.
First, let's start with the most important priority for the legislature in 2021 as it pertains to our mental health. Is there, and I'm going to ask this of all of you, so prepare and think about what that one thing is that you would bring forward or submit. But Joaquin, what's highest on your radar or on your list as it pertains to the health of Californians as you look at the session that will kick off in January?
I think we're going to have to get control of COVID as a state. And for that, I believe we're going to need a federal partner who's providing some real direction, vision, as well as resources to allow us to combat this vicious virus head on. I would like to talk about telehealth, though, if I can, as it will be a major focus for my office in this upcoming year. In previous sessions, I've introduced legislation as in AB 340, which dealt with adverse childhood experiences, and ultimately led to our state hiring a Surgeon General who specializes or works in this area, in this field, and believes that that is a screening tool that allows us to identify students or children who have the greatest needs. But what it doesn't do is allow us to connect them with services. We haven't been able to then say, here's a psychiatrist or a therapist or someone to follow up with once we have screened and identified that there has been trauma that has occurred in your lifetime. And so I see an opportunity here for us to break down silos between healthcare and education, for us to work with and think about what social emotional learning is and should be for our communities. I'm looking forward to working with our Surgeon General as well as our Superintendent of Public Instruction, as well as the administration, who has shown quite a bit of interest in this area, to figure out how we can rise out of this stronger. But it fundamentally must be us looking towards telehealth and specifically behavioral health as a solution. I am a true believer now that we have increased access to care. We are better able to connect people with culturally and linguistically competent care by using telehealth, and really believe we need, as Dr. Hernandez said, it should be here to stay.
Great, thank you. And so just a precise follow then, will you focus on telehealth in the 2021 session? Is that part of your plan?
Yes. Our office is going to be working with those other offices that I mentioned, and I think it's important for us to figure out funding streams. Dr. Hernandez alluded to payment parity, which was one of the flexibilities that we gave during the pandemic, and believe that's something we need to continue long afterwards, as it will help us to figure out the gaps that we have in our healthcare system. And so we'll be excited to work on telehealth and behavioral health in this upcoming session.
That's great. Thank you. Kieran, in your opinion, or from the vantage point of CPEN, what's the most important thing that needs to happen as we look at the legislative session in 2021?
So I think fundamentally, what we really need to change in behavioral health is we need to bring care to the community, right? Right now we have a healthcare and a behavioral health system where folks have to go to their healthcare, right, to their provider. So telehealth is one piece of that, but the other piece of that we believe is really looking at how do we create types of mental health care that are really rooted in communities? So I described a few examples of that in the beginning, but fundamentally what that means is that we have to embrace those models, those really community-driven, community-defined models as part of mental health care. We have to fund them, we have to integrate them so that we are able to refer between primary care and those types of programs, and vice versa, also including substance use, right? And so that really looks like changing how we think about what healthcare means in communities and how we pay for it.
Okay, very good. And Dr. Hernandez?
Yeah, I would agree with Kieran and Dr. Arambolo as well. I mean, I look at this pandemic and what I see is this tremendous disruption that has occurred in all of our delivery system. And as Kieran references, we have a very fragmented delivery system, particularly for mental health in this state. And anytime you have a major disruption, I think it's an opportunity to really think about what kind of delivery system transformation we can make that makes us come out of this stronger. And we've been, CHCF has been doing quite a bit of work really to bring our county mental health system, our Medicaid managed care plans, our delivery systems, our integrated delivery systems, really to a common table to really address what Kieran is saying, which is how do we build a system that is easy to access, it's culturally appropriate, that is timely, and that does not put the onus on the individual who is in whatever type of mental health crisis they might be in to get to access care. And so the opportunity to look at delivery system transformation, and as Dr. Arambolo mentioned, having a new federal partner to really understand the Medi-Cal program and how we can use that program through waivers and the like to create a delivery system that really does integrate fully primary care, prevention, education, early interventions, screening, ACE screening, and really create the seams within our delivery system that make it simpler and easier to access the capabilities that we have now. So I would say delivery system transformation is at hand. We're doing a lot of things in real time to respond to a pandemic. We want to reflect on what worked and what didn't work, evaluate that. But I think fundamentally what we have seen now, and I think the entire delivery system recognizes how important the counties are. A lot of our workforce in mental health are in the private sector. How do we engage the private sector with our health plans, delivery system, with our clinics? And so when you have a crisis, it's an opportunity to really rethink your system design and how it works, and thinking about it from the point of view, in particular, of folks that have the kind of social determinants that Dr. Arambolo referenced in his early remarks. That is our opportunity. And so whether it's through waivers, whether it's through pilots on integration, I think those are all opportunities for us, given this disruptive period and given this acceleration in telehealth and really understanding how that works.
That's great. And Dr. Arambolo, did you want to add to some of the comments that Dr. Hernandez made? Please jump in.
No, I really wanted to follow up on a nuance of what she said, if I could, which, you know, if you're not a policy wonk and spend time looking at financing of healthcare, you might not appreciate. But the brain isn't treated as every other organ in the body. And I believe it really creates a bias within the system that hurts those who have mental health issues. And so really wanted to pick up on it and speak about it. If you have a heart condition and it's mild and it gets to severe, your healthcare will still cover you. But if you have a mental health issue that starts as mild and you eventually get to have a severe exacerbation of that issue, you're not covered under the same funding stream. And because of that, because you're not covered under the entire spectrum of care, I really do think we have to look towards system changes in this moment so that we can create that parity and treat the brain like every other organ in our body. I did want to mention, since I also heard it from Kieran and didn't want to miss an opportunity to talk about a local program, one we're doing here that I was at just a week ago that has really helped with mental health in our community as well. Just to give you a flavor or an example of one that has worked. We've been working on a sweet potato project, in that reducing disparities project that she mentioned under CDPH, where people in our community, African American boys and girls, are growing sweet potatoes. And when they harvest them, they learn leadership skills and entrepreneurial skills by turning that into a product. But what they told me this last week, this is their outlet. This is their chance to have friendships and normal social interactions for those who are 12 to 15. And sometimes it is the simplest things for us that we need to look towards that will help us to reduce these disparities. But we must have an eye both on system changes and what is working on the ground, and just wanted to add that to the conversation.
That's great. Any opportunity we have to elevate the successes and to replicate the wins is an opportunity that we should take. Before we move on from the legislative priorities in 2021, I have one final question. This one's for you, Dr. Arambula. We talked we talked a lot about police reform in 2020. We introduced a number of bills through the legislature, both before the events of the summer and after. And few of them, as you know, passed. We know that mental health and racial equity are connected. What are you looking at with respect to racial equity in 2021 and where we can be better?
But systemic racism is quite real for so many of our communities and how we access care. And it's why we're seeing the disparities within healthcare that we see. The results here within the pandemic are shocking and frankly should lead us towards action. But if I can, I have been a critic for a while that we haven't been producing enough providers. We haven't had a workforce that is reflective of our communities. So often I found in my own practice, it was being able to break barriers down because you could speak in their native tongue, because you could understand and have some cultural ability to relate, allowed you to build trust as a provider. And so often right now, I believe we are looking at a workforce that is feeling pandemic fatigue, that is struggling to continue to be the heroes that we need them to be day in and day out. But I hope one of the things the legislature works on in this upcoming year is workforce, as Dr. Hernandez mentioned. It was a problem before this pandemic. It's being exacerbated by this pandemic, and there really is an opportunity for us to figure out how we make that workforce more reflective. I will be specifically, if you will allow me a moment to talk about it, looking at HCOP, which is a Health Career Opportunities Program. It is a federal program, and we've had a state HCOP in the past, but we do not now. And I think there's a real chance for us to look towards pathways, for us to encourage our high school students and college students of the moment to help to meet this day, to meet this moment by going into public health, by figuring out how to be a therapist or a provider or an RN. And so I really hope we take this chance to make sure that we are looking towards and training the workforce for tomorrow. Lastly, since we are still talking policies that will improve and make things better for the next year, I could not help but mention that we need to put comprehensive immigration reform on our president-elect's desk within the first 100 days of his presidency, as this will vastly allow us to bring people out of the shadows, to include them in our communities. And I think it will be one of the most important things that we can do for our state and our nation.
So I just want to jump in here, if you don't mind, and say, I wholeheartedly agree with the policy solutions that the Assembly member has put forth here. And I also think when we think about racial equity and we think sort of across systems, right? We look at healthcare and behavioral healthcare. We look at criminal justice, like you mentioned, Lauren. We look at economic opportunity. I think we have to fundamentally realize that structural racism is deeply embedded in these systems. And so in large part, the outcomes that we see are sort of what the systems were designed to do, right? And so if we want to see different outcomes, we have to really flip things around and dismantle, I think, those elements of discrimination and bias and inequities that we see across the systems. And that's one of the reasons we at CPEN and many organizations, hundreds of organizations across the state, have called upon the governor to declare racism to be a public health crisis, because it is. And when we talk about mental health and equity, we really do have to have an explicit focus there. And I very much hope that the legislature and the governor and our federal administration too will embrace that this coming year, particularly given the sort of outcry that we've seen in our communities to really tackle these systemic issues.
Really, you can't solve any public health crisis, let alone take on systemic racism in our healthcare delivery system without really having the folks for whom you are trying to solve problems at the table. This is fundamentally a question about power. It's about cultural competency. And it is, we have a system that works primarily for those who are in the system as providers and not really designed to address the kinds of unique needs that our communities actually have. The advocacy and the vocal participation of people for whom we are most trying to serve, when we incorporate them in the design of our programs are going to be that much more successful. And really, we're under-resourced, not just in mental health, but certainly in public health.
That's great. Thank you so much, all of you, for your time. You've deepened my understanding. I know you will deepen others as they have an opportunity to view this program on demand. And again, it will be shown across all 5 McClatchy, California properties. And in closing, I would just remind folks that if you or someone you know needs help, there are supports available. You can call the California Peer Run Warm Line at 855-845-7415. You can also text Talk With Us to 66746 to connect with a trained crisis counselor. Thank you for your time today. Hope you have a great afternoon, great morning if you're viewing in the morning, and that's it for us this morning.
Awesome. All right. So I hope folks have had a minute to stand up, get some water, get yourself some coffee, a treat, get your lunch, whatever you need to do to take care of yourself. We're going to now transition to our last but not least final session of today. I want to introduce our speakers. This last session will be moderated by CPEN's Community Advocacy Director, Mihei Jung. She oversees our mobilization and grassroots partner strategies here at CPEN. I'd like to introduce our first panelist, who is Lupe Solario, who serves as the Vice President of Capacity Development and Sustainability for Community Partners. I'd like to introduce our second panelist, Joel Baum, who's the Senior Director of Professional Development and Family Services at Gender Spectrum, and he is responsible for all programmatic aspects at Gender Spectrum. And lastly, Ruben Garcia, who is the Clubhouse Program Manager for the Fresno American Indian Health Project, and he is a member of the Manchester Band of Pomo Indians. So I'm going to pass it over to Mihei now for the discussion.
Thank you, Carolina. My voice is gone officially, and so I apologize if folks can't really hear me. I'm feeling a little bit under the weather, but I'm here. Thank you so much for being here. And I don't know about you, but I'm really inspired by all the conversations that happened prior to the panel. And I'm even more excited to share with you the panelists that are joining with us today. I think it's notable to, it's important to note that, you know, these local programs are the programs that are making a difference, that are currently reducing disparities for communities of color and LGBTQ populations every day, pre-COVID, post-COVID, nights, days, and weekends. And so that's why I'm so honored to have our guests. So today we have 3 programs across California that are aiming to provide services and reduce disparities every day. And across California, as we've heard, we continue to see worsening of mental health disparities in communities of color. This is not okay. It can often seem as if these disparities are intractable, that mental health disparities are the result of individual choices. Rather than lay blame on individuals, we have to recognize that systemic racism, xenophobia, transphobia, and homophobia have resulted in the absence of programs that meet the needs of communities of color and the LGBTQ communities. Some of the programs that you'll learn about today are demonstrating positive outcomes in communities of color right now and today, who show significantly lower rates of access and outcomes in mental health, while the other programs are experimental, yet demonstrate a commitment to meeting the mental health needs of the uninsured. So ultimately, the goal of the discussion today is to discuss 3 experimental and evidence-based policies and programs aiming or providing to reduce mental health disparities in communities of color across California. We will be discussing how these program models are working to address the population-specific needs of communities of color, the impetus for the program and the outcome, and what else must be done to ensure the integrity of these programs. We will also give you, have the panelists give you recommendations, if you're interested, how you can work to scale these types of programs up and across California. And a flag for the audience, if you are curious about the materials that the panelists have prepared, they're actually available on the CPEN website. And so our wonderful moderators and folks that are managing the chat box should be able to drop in links, any kind of fact sheets and brochures that you could take a look at to learn more about these programs. Okay, great. So we're gonna get things started. So Joel, Ruben, and Lupe, welcome. Maybe wave your hand a little bit for the attendees. There you are, great. So please share your name, your position at the organization, and the brief description of your program that you're gonna be talking about and the population that the program is serving. So let's start with Joel.
Thank you, Mihei. Hi, everyone. Again, my name's Joel Baum, and I am the Senior Director for Professional Development with Gender Spectrum. I am also the Education Director at the Child and Adolescent Gender Center at UCSF Hospital. And I'm really, really proud to be here. Gender Spectrum is an organization that focuses on creating gender inclusive worlds for all children and youth. And I want to pause actually for 1 second. I'm coming to you from San Leandro, which is actually located on the unceded land of the Chochenyo communities of the Ohlone tribe here in the East Bay, and recognize that I occupy land that has never belonged to me. And also I'll share that my pronouns are he, him, and his. Sorry. So our organization works to create gender inclusive spaces for all young people. And the way we try to do that is by engaging various clients in conversations about gender. And in the time that we've been doing this work for now close to 15 years, 3 really critical ideas have emerged around this work. The first really builds on much of what we were talking about earlier in the other panelists, which is the intersection of gender with other forms of identity and the importance of recognizing that gender is mediated in many cases by these other forms of identity. That is, gender as a concept is one thing, but to talk about the experience of gender, particularly for young people, we have to account for many other aspects of their lives because issues such as religion and race and culture and language, ethnicity, and many others really impact how that young person's gender plays out. We also work very hard to meet people where they are, particularly the adults and other caregivers working with young people who may or may not necessarily know a lot about gender or have much background. And yet we know that we all come by our notions of gender quite honestly. And so we work very, very hard to come to our work by calling people in and not calling them out, by really engaging them in an honest conversation. But we're also fond of a saying around here, which is, it's okay not to know, but once you know, you can't not know. And then you have to decide what you want to do about it, which is much of the work that we do. And finally, we recognize gender's impact on all of us. Our project is focused on helping support transgender and non-binary young people as part of the LGBTQ+ hub of the CRDP. But we also start from a place that recognizes that gender is something impacting all young people. And so we believe while this work is absolutely life-affirming for all young people, it is certainly life-saving for some of them. And that is in particular our transgender and non-binary young people. Mihai, is it okay for me to talk about the project really quickly and then be done?
Yes, and we'll go over to Ruben after for him to introduce his project.
Okay, great.
Should be fine. Go ahead.
Our project is based on the work that we do in schools, which is really in many ways different from a lot of the other projects, because our chain of our model of change, our theory of change is a little different than many of the direct service providers. What we seek to do is work with school communities to deepen their understandings of gender so that they can create more gender inclusive conditions in those schools, which then our trans and non-binary young people can see themselves represented as those schools seek to support them and all students when it comes to gender. Really, we're looking at, this is work we do all over the country and have been doing for many, many years. And so in that way, it is experimental in that what we're trying to measure for the first time is the long range impact of that work. And it really comes in two forms. We do sort of a basic, quick and dirty 2.5-hour workshop designed to deepen gender literacy, as well as a more in-depth program called the Inclusive Schools Network. You can see here some of the data from who we've worked with, and I'm excited to share some of the results of that work as well when it's appropriate, but I'll stop there.
Thank you, Joel. Let's go to Ruben. Please share your name and your pronouns, position and the organization you work for, and a brief description of your program and the folks that you're serving.
All right, thank you, Mihai. And thank you, Joel, for that acknowledgement there for the Indigenous people there in your territory. That's a part of really what we work for too, is to address that invisibility and erasure sometimes of Native tribes. So my name is Ruben Garcia. Again, I'm a member of the Manchester Point Arena Pomo tribe. I'm currently in Fresno, and the most local tribe where I'm sitting is the Dumna tribe. Might be one that's unfamiliar, as we know, but there's quite a few tribes here in the Fresno area. My pronouns, he, him, his, work for me. And then I work for the Fresno American Indian Health Project, which is a urban Indian health center here in the Fresno city area here. And we service the American Indian Alaska Native population here. And more specifically for my program, I work with the youth services. We work with the K through 12 students, and then we also work with the transitional age youth as well. And a big part of what we're doing here is mainly at the Health Project. We actually were started in 2010 to really address some of the mental health needs that were here in the Valley. And that kind of started with a needs assessment that was done, a community needs assessment, and, gathered a lot of useful data there and really got our project going. It wasn't until 2011 and 2012 that we really got involved with our GONA project, which which we're currently running with the CRDP and a couple other cross sites through the Native communities here in California. That's, our GONA. I'll get a lot more into that, but, just really looking into how we're creating culturally specific interventions for our youth. Specifically, our project has been doing 9 years now of these GONA interventions, and we're seeing a lot of great outcomes, and that's really specific towards the 13 to 17-year-olds. However, we're really starting to see some capacity building, and a lot of what we're seeing is volunteers from our early cohorts coming back to really provide some of the service that we have provided for them, and it's a continuing process. And I'll talk a little bit more about that, as we do have a longitudinal study going with that to see, kind of check in and really keep that study ongoing for our teen population, our native teen population. So I'll stop there, as I'll have a little bit more to share later.
Thank you, Ruben. All right, let's go to Lupe.
Thank you so much. My name is Lupe Solorio. My pronouns are she, her, hers, and I'm on Chumash land to respect the land that I don't belong to. And I'm vice president at Community Partners. And if you see, my title is very long because it's around capacity development and sustainability. And it's really, our organization is focuses on building the capacity of nonprofit organizations. And so the partnership that we have with the County of Los Angeles Department of Mental Health is a key partnership that we began about 1.5 years ago. And it's a recognition by the County Department of Mental Health that there are community organizations, grassroots organizations that are trusted by community members to deliver services, right? And it's so important for these grassroots organizations to provide preventative mental health services. But they have a challenge in trying to receive county contracts and funding, which is typically large pots of money that they just don't have access to because of the size of their organization, not having the infrastructure. And so they partnered with us to provide capacity building support so that they can have that opportunity to become effective contractors with the county, while still having a little flexibility that they wouldn't normally have if they became direct county contractors. There are many challenges to being a county contractor, from, it's a cost reimbursement type of arrangement. You have to have so much reporting because a lot of the dollars that the county is administering come from the state. And so this was their opportunity to try to see and pilot test a program where through a private public partnership, we are doing many things, not only providing training, but we've partnered with private funders to provide some funding so that we can help them with certain things that the county dollars cannot pay, such as equipment, software. So it's a recent partnership. We just implemented in October, we started the training intensive. So we have lots still to learn from the engagement. And in a way, we've been trying to be very flexible, right, to the needs of organizations, because these are small, sometimes, all volunteer organizations, but yet they are trusted. They provide wonderful services. As many of you know, if you work at a nonprofit, we do a lot with very little money. And so this is a way to kind of engage the smaller organizations to provide preventative mental health services.
Thank you, Lupe. And for those of you that want to learn more about community partners, collaboration, the capacity building program, I think Carolina and Monica are dropping in links. And I also want to communicate that this was a board motion, right? LA County Board of Supervisors passed a board motion recognizing that, grassroots and community-based organizations, it's difficult for them to be county contractors due to organizational capacity issues and operations. And so, organization like yours is, contracted to provide trainings and resources and capacity building to these organizations so that it can be brought up to a level where they can be, they have the capacity to be county contractors. So, if other counties are wanting to do this, you can, right? You can work with your board of supervisors to pass a motion like that. And there's a model that's already going on in LA. And Lupe, thank you for joining us. Okay, so the next part of the sort of questions that I'm very curious about is around data. And we're talking a lot about data today. And earlier, I heard Chet talk about the 70% of young people have reported that their mental health is not doing so well. And knowing that, Joel, the folks that you're serving, young people, that a lot of LGBTQ, trans, and gender expansive youth, they're part of that 70%. And Ruben, Native American young people, they're part of that 70%. So the programs you're running are making a difference, And so, Joel, I want to invite you to talk a little bit about data and how did data help inform the genesis of your program, and what's been the outcome that you are seeing so far?
Thanks, Mihai. Yeah, I would say, the data that we started with is some of the stark numbers about the experience of transgender and non-binary young people in our schools. We know from multiple national surveys that transgender young people are far more likely to be bullied, to be far more likely to feel unsafe at school, to potentially bring a weapon to school for their personal safety, to be pushed out of school, and not only to face bullying, but physical assault and sexual assault. And unfortunately, not only do many of these things occur at the hands of their peers, but even in some cases at the hands of the adults around them. We also have data that really points to beyond these sort of basic Maslowian aspects of survival. But our trans and non-binary young people report having less considerations for having family or having a happy future or being able to be happy in the community in which they live. The data could not be more stark. And we know that our trans and LGBT young people come from all communities, right? We're not just talking about a certain subsection, but across racial groups, across ethnic groups, across religious groups, economics. There are trans and non-binary and queer young people in every one of our communities. And so the data that we have looked at pointed to a real national crisis. And this is happening in schools across the country. And so that data certainly has given us impetus to the work that we do. We also know the data is in particular challenging for those young people who do not have affirming caretakers at home. And so those young people are at even much higher risk, including for suicidality and non-suicidal self-injury and other really negative health outcomes. And so our theory of change was very much based on creating conditions in schools where those young people would feel seen and safe and supported. And the way we've sought to do that is by really building the capacity of schools to proactively demonstrate their awareness of gender and gender diversity. What we hear over and over from young people is they don't know who is and isn't safe. Schools spend a lot of time saying, talk to me and we're here to help you. But in the absence of information, students assume they're not safe, the adults are not safe. And even when we tell them we are, talk is cheap, right? They want to see action that truly indicates this awareness. And so the work we try to do is really grounded in demonstrating that awareness of gender. And we're really proud to say that the data initially is showing that not only in a short-term way are the educators with whom we're working changing their understandings of gender, but the initial reports are also pointing to much longer term impacts in terms of those school systems and those school structures. Much of what was spoken about earlier about systems and structures changing in ways that account for gender when it comes to young people. And so we feel really, really excited about the changes we're seeing. It's a long chain of effects, and we recognize that. But I think in keeping somewhat with Lupe, it's about building the capacity of the schools with whom we're working. So when we leave, this work continues. And that's what we're really starting to see. Changes in policies, changes in practices. We have a model that looks at different, what we call entry points for how schools can proactively demonstrate their gender awareness. And it's something that we're very, very excited about. And then I'll finish by saying, and this has been informed by our community itself, both the community of transgender and non-binary young people and caregivers, but also in an area of work that we know we certainly need to continue to do, which is around our own cultural humility and ability to fully incorporate the voices and rich traditions of gender that come from many, many different communities. It's not as if gender diversity is new. We've had gender diversity across all communities throughout history, whether they're indigenous cultures and the broad notion of being two-spirit, whether it's individuals in the Pacific Islanders and the Mahu. You can go to any part of this world and find a rich history of a recognition and celebration of gender diversity. And that's really what we're trying to build on in creating schools that feel a little bit safer for kids, and particularly for those kids who don't have the support at home. These schools become a safe harbor for them because it may be the only place they're hearing that they're perfect just the way they are.
Thank you, Joel. All right, let's go to Ruben. So earlier you spoke about 9 years of the GONA project, and the GONA stands for Gathering of Native Americans, and I believe it's national, right? And so can you talk a little bit about those 9 years of collecting outcome data? And you said that you had some data to share, so would love to hear that.
Yeah, thank you. We're going on our 9 years, and really, again, going back to our community needs assessment to show that this was not only a need for cultural identity, was one of the biggest things that had come up in what we've seen in our needs assessment, and really how are we going to establish that for our young people? Because one of the things that was also brought in there was looking at how are we going to carry on traditions and culture, and that's really how we're going to ground ourselves in that, to make sure that our youth here in our community have that sense of belonging and can thrive. And so GONA was one of the things, and yes, it is national and it's been around. I think they just celebrated the 25 years last year, so just over 25 years it's going. And there's a saying that there's a GONA going on anywhere in Indian country every day. So and some of the data that we've been collecting since the beginning is we've been really collecting the cultural connected. We've been utilizing the cultural connectedness survey, and then also the Hope Hearth Index. So really kind of looking at how those two correlate as we provide the intervention. And at this GONA camp, it is a camp, and it is a 4-day intervention. It's been implemented in 2 days, in kind of a shorter sense, especially right now in the virtual world, as things are kind of getting tapered down to really fit that virtual sense. But the GONA incorporates the value of 4 levels of human growth and responsibility, and it's grounded in Native American culture. And those 4 concepts and principles of the curriculum are belonging, so really creating a sense of belonging and cultural identity and safety within communities for these young people, and then mastery, really kind of looking at some of the impacts of historical and intergenerational trauma, and really kind of addressing those challenges that we're seeing in not only our youth, but our families and communities in whole, and really looking not necessarily at some of the disparities and focusing on that, but really getting into the realms of resiliency and looking at how our communities have been able to survive and strive and adapt in so many different situations, and really look at how to empower not only themselves, but the community and families as well. And then the third principle for the curriculum as well is interdependence, looking at how we can take action and organize in our community. How does community leadership look? All with an emphasis on culture and wellness. So that's what revolves around is wellness, and looking at really going back to some of the tradition and cultural values that have worked over time and have or do continue to work for our communities. And that fourth concept is generosity. So it's really looking at how we're going to give back to our communities and how we hold that responsibility, not only for ourselves, but for the generations to come. And I feel that, going through these 4 principles in our curriculum, by the end, when I first started, I started as a volunteer and just really got in to say like, hey, I want to support youth. But after I seen that, that 4-day transformation, it was something that had me sold for the rest of my life. And that's what we have some of our evaluation. We have a lot of elders and people who have committed a part of their life to be a part of this process. So that's really has shown really like we have such a really invested community that's willing to carry on this work and look at how it impacts not only our communities, but also how our communities are accessing mental health services. And that was a big part of what we wanted to do, was really incorporate our behavioral health services that were offered here, because it was a challenge. When we started with a Circles of Care project and through SAMHSA, and one of the major challenges was really just increasing access to that service. And the GONA really had given us an avenue to really express how effective not only this curriculum can be, but also how it can lead to more intervention with our mental health and behavioral health services here at the Health Project. So we're seeing a lot of that. And, over the time in our evaluation, what we're seeing is that the more the higher the connection with culture and community through that connectedness scale, the higher level of hope and increase that that we're seeing over time. And so that that has shown that it's really been impactful. And then also with again we do have a retrospective study that we're participating in, also for those youth who have aged out and are aged up and are 18 and up now, and who really have carried these teachings and principles to the next level, and how it has impacted their lives positively. So we're seeing a lot of outcomes and engagement from not only our transitional age, but our communities really invested.
Thank you, Ruben. All right, so Lupe, I'd love to hear from you some of the outcomes that you're seeing from your experience of supporting CBOs with your program.
Sure. So, like I mentioned, we're barely in the initial phases of the program. So I will say that, we had to do a little bit of a pivot when COVID hit, because, the Department of Mental Health really understood that there was going to be such a greater need. And so we wanted to open up the pool of applicants to organizations that could do that pivot, could be a provider for communities in Los Angeles. So I think where I've seen, definitely at least an impact that we've had is in just even applying to our initiative. There was a barrier. They had to be on this, master services agreement list. And if anybody knows that process, it is a process of just submitting documentation to the department to say I'm a legal entity, right? And people had difficulty. We had to conduct more trainings around that and make sure that we were helping people, even if they didn't get selected to be part of our cohort, that they were able to get onto that list. I had to conduct one-on-one consultations just to walk people through, because it becomes very daunting as you read the a county solicitation and you're trying to figure out what's needed. We saw a great need for that, and we tried to meet that need. So we ended up selecting about 29 organizations, And I will say that just in the first 2 sessions, I think people have gotten information that they would normally have gotten. We are doing an organizational assessment with them. So when they applied, when we accepted them, we sent out an organizational assessment so they could tell us where they are in their developmental stages. And out of that, we're going to have them choose an area that they'd like to focus on while they're doing the program, so that then they could, we can then pair them up with consultants, coaches to help them through that developmental stage. Mihei, thank you for pointing out that it was a board motion, and the board invested $5 million into this initiative. So that so really important component of this is that while we train them and tell them, what they need to do to be an effective contractor, in the second part of this initiative, they get a small, about a $200,000 contract that's administered by us, and they implement what they've learned throughout the training session and actually run a program in their community doing the work of providing preventative mental health. So I think that's where we'll see how much impact we've actually had through our training, through our through the consulting and coaching. And so I feel like we're still new to that, so we don't have as much data as I'd like us to have, but we've been trying to be flexible, right, during this period, so that we're meeting them where they're at, at this point in time.
Mm-hmm. Thank you, Lupe. Thank you, everyone, for sharing the outcome data and your experiences of running the program. It is 1:55, and we are slated to close this entire briefing at 2, so I want to be mindful of everyone's time. But if I can just ask one thing from the panelists, if you can just pick one policy change that you would like to see, what would that be, right? And if you could keep it short and sweet, just final, like the parting words for the attendees. There's some folks from the department that are, listening in, and I think it would be helpful to share what you think as like that one policy change you'd like to see. So Joel, let's hear from you first.
Thank you. Yeah, I'm conscious of being the time. So I guess the one policy thing I would like to see, and I think this fits in the policy realm, is that for the earning of any sort of mental health license or certificate, there be a requirement for some form of gender literacy training. Every working professional needs to understand a little bit more about gender, and we need to incorporate that into all of our licensing processes. So that would be my recommendation.
Thank you, Joel. Ruben, what do you think?
For me, I think it's really just going back to, especially for the Native American communities, just to really emphasize that, to continue, of course, to fund culturally appropriate services and really look at how culturally appropriate interventions can be funded more.
Right, going on for 9 years, and there's a lot of data out there. So yes, more funding for culturally informed practices. And Lupe, let's hear from you.
I would say the one thing that, just because of the work that I'm involved in, I would say the one thing that I would want to see is the ability for nonprofit organizations that are on the ground. It's difficult to be in a cost reimbursement relationship with any county or any state entity, right? And then not be able to have an advance on the funds. They are doing so much good work in the communities, and the barrier to them becoming a contractor is, it's a state requirement, it's a county requirement, federal funding is this way, right? So it's a lot to ask, but I wish that there would be, maybe more partnerships so that small grassroots organizations could get some upfront costs taken care of.
Thank you so much, Lupe. Well, I think I am happy to pass the virtual microphone back to Carolina. Thank you, panelists.
Thank you.
Thank you.
you.
Yes, thank you so much. Thank you so much for that insightful discussion. I think it's given participants a lot of food for thought about how we can move forward based on the best practices and lessons learned from the work that all of you are doing on the ground across California. Just wanted to thank all of the participants for joining and let you all know that we will be posting recordings of both day 1 and day 2 on our website. So please check it out. If you haven't signed up for our mental health newsletter, please do so. We will be launching a newsletter in January. And lastly, if you have any questions, comments, feedback, you want to get connected to any of our speakers from day 1 or day 2, please feel free to reach out to any of the CPEN staff, any of the speakers here, Joel, Ruben, Lupe. Don't mean to put you on blast here, but feel free to drop your contact information if participants want to follow up with you, or feel free to contact me as well. My information is on our website. So yeah, thank you all so much for joining and have a great rest of your day.